I'm going to be going over oxygen delivery to the tissue in this video, and before I get too far ahead of myself, I just want to make sure that I write that oxygen delivery to the tissue is equal to cardiac output times the amount of oxygen in your blood. In one of the other videos, we were talking about how blood pressure is a pretty useful surrogate measure of reasonable circulatory function. This is to say that when someone's blood pressure is in the normal range, you are somewhat reassured that they probably have reasonable end organ perfusion. But of course, we know that blood pressure is equal to cardiac output times systemic vascular resistance. And what we really care about is cardiac output, and specifically how much oxygen we're carrying to our tissues. So the most ideal monitor really would be something that would sample the oxygen tension right around whatever tissue we're interested in, so the brain, heart, or liver, or whatever. And then we would know if the amount of oxygen around this tissue is high, that we are supplying a sufficient amount of oxygen to this to meet its metabolic demands. This is not what we do. We don't really have the means or resources to do this. So instead, cardiac output is a reasonable surrogate for that. And the reason why blood pressure isn't always the best way to assess your oxygen delivery is because we so often manipulate systemic vascular resistance. As soon as we give a general anesthetic or even a spinal, we're dropping our SVR, and then first thing that we do is give an alpha-1 agonist like norepi or phenylephrine, something that causes vascular squeeze and restores or even increases our systemic vascular resistance. So we drive up our systemic vascular resistance and our blood pressure goes up. But this hasn't really changed our cardiac output. So by manipulating the SVR, we're essentially decoupling our cardiac output from changes in our blood pressure. So if we want to know what's happening to the tissue perfusion, we sometimes need different monitors to keep track of cardiac output. What I'll propose is that instead of monitoring the oxygen tension directly at the tissue level, we can sample the venous blood, return the venous O2 sat, to give us information about the cardiac output. When the venous O2 sat is low, we must have lower delivery of oxygen to this tissue. Therefore, this suggests that our cardiac output is low. Let's look at someone with sepsis, for example. And we know this is a distributive shock. So this person will be hypotensive, and we'll use norepi as our first line vasoactive agent. We'll give a little bit of this. It'll have alpha-1 action primarily and some beta activity. So this may restore our preload by causing venous squeeze, and will increase our SVR. Now if we uptitrate our norepi and just give a whole ton of this medication, we'll still get this increase in preload, but there's definitely a lower ceiling effect to this than there is for the increase in your afterload or systemic vascular resistance. So while we maintain this venous squeeze, we more significantly increase our systemic vascular resistance, and therefore we have much higher blood pressure. But here we'll actually have lower cardiac output, or perhaps even decrease end organ perfusion, depending on if we've given such a high dose that we're vasoconstricting to the point that we're not properly perfusing our end organs anymore. So here, since we have a lower cardiac output, if we were to do a mixed venous gas, it would be lower, to reflect that we have relatively less oxygen delivery to this tissue in spite of our nice looking blood pressure. So in this case, this would be a useful tool to help you guide the resuscitation of this patient and suggest to you that strictly driving up their systemic vascular resistance to increase their blood pressure is not an effective therapy. We'll come back to this example after I've gone a little bit more in depth into this. There are two determinants of your oxygen delivery, and we'll call this the supply. Number one is the tissue perfusion. As we said above, this is the cardiac output, and our blood pressure is the cardiac output times the SVR. I'll say this again for sake of repetition, that we use a alpha-1 agonist that may cause vasoconstriction and increase our SVR and increase our blood pressure, but actually decrease our cardiac output. So in this case, our blood pressure is essentially uncoupled from our cardiac output, and our blood pressure is not a useful monitor for tracking our tissue perfusion in this case. The second determinant is the blood oxygen content, which is your hemoglobin concentration, and then the saturation of said hemoglobin. You should become familiar with this equation to calculate how much oxygen you can fit into your blood. And this is just your hemoglobin concentration in grams per liter multiplied by 1.34 milliliters of oxygen per gram of hemoglobin. So that's how much oxygen will fit onto a fully saturated gram of hemoglobin, and then you'd multiply this by the saturation of your blood, which here we're assuming is 100%. This will give you the content of oxygen in your blood. So this would be 160 mils of oxygen per liter. The amount of oxygen that's extracted by the tissue varies depending on what tissue you're perfusing. So your brain uses a different percentage of oxygen that it's sent than your liver and your heart. And this depends on the blood flow and metabolic rate. So again, supply and demand of these organs. I'll just write some oxygen extraction numbers here for your reference. The only one you really have to know is the heart, which is about 70% oxygen extraction. So it uses 70% of the oxygen that is brought to it, and then your venous blood is 30% saturated as it empties. And your heart empties into the right atrium through the coronary sinus. The brain extracts about 40% of the oxygen that it's sent. Muscles in an inactive state use about 15%. The kidneys also use only about 15%. This is not to say that they have a low metabolic rate. They actually receive 25% of your cardiac output. So they receive a high amount of blood flow and then just extract a relatively low proportion of the oxygen from that high blood flow. Your splanchnic circulation uses about 30% of the oxygen, with the exception of your liver, which has a higher oxygen extraction. And this will actually approach 100% in low blood flow states. These numbers are all with normal cardiac output and at rest, or resting metabolism. So as you can imagine, the muscle will significantly increase its oxygen extraction with activity. And all of these organs will increase their oxygen extraction when they have low cardiac output. Although we're not going in to measure the venous blood directly leaving any one of these given organ systems, what we can do is use a central line or pulmonary artery catheter to measure the mixed venous saturation of all of these organs together to give us an assessment of the global perfusion. So a PA catheter, or pulmonary artery catheter, samples mixed venous oxygen saturation from all of these organs together. That goes in down through the SVC, the right atrium, the right ventricle, and up into the pulmonary artery, and then we'll sample the blood from here. So clearly this is a mix of blood from the brain and upper extremities, kidneys, splanchnic, and lower extremities, as well as the heart, which empties into the coronary sinus here. The PA catheter is rather invasive, so we can also just use a regular central line, and then we'll be sampling blood maybe from the SVC if it's a little bit short, but probably blood from our right atrium. This is called the central venous oxygen saturation. If you end up sampling just from the SVC, you'll get brain and the upper extremities. And then if you sample from the right atrium, you'll also get blood flow from the lower extremities after it mixes. So you'll get all of these organ systems as well. The only one you definitely don't get with the central venous O2 sat is your heart, because where you're measuring it, there will likely not have been the full venous mixing from your coronary sinus. As a result of this, the central venous O2 sat is approximately the same as your mixed venous sat, but your mixed venous sat tends to be just a little bit lower by 2 to 3% because it has this highly desaturated blood returning from your heart that your central venous sat doesn't pick up. One caveat to this is that your central venous O2 sat may be quite a bit higher than your mixed venous O2 sat in cases where you have a general anesthetic with decreased metabolic rate of the brain or traumatic brain injury, or shock with a significantly increased metabolic rate of your lower extremity or splanchnic circulation. This is only the case when you're only sampling the superior vena cava blood, because then the differences between the metabolic rate from your brain and the rest of your organ systems will be accentuated. Anyways, all of this to say, we have this nice way of measuring our oxygen extraction with our central venous or our mixed venous gases, and a decrease in cardiac output will increase the extraction. So if we have a lower cardiac output, we'll have a lower central venous and lower mixed sat. Therefore, we can monitor our venous sats as an indicator of cardiac output, and importantly, oxygen delivery. Think about these shock states: cardiogenic, obstructive, hypovolemic, and hemorrhagic shock. These are all characterized by decreased cardiac output. Therefore, they'll all be associated with a low central venous oxygen saturation. So what we may do here is track the central venous sats and target them to be greater than 65%. So we may need to use inotropes to increase our cardiac output, or maybe volume is going to be the answer, especially if we have hemorrhagic or hypovolemic shock. But importantly, vasopressors are not going to fix our cardiac output problem. Whereas in a distributive shock, our cardiac output should be relatively the same or sometimes even increased, unless we're distributed to the point of having low preload, which I'll say often is the case before initial resuscitation. But in this case of having normal cardiac output or even slightly increased cardiac output, the ScVO2 here will be normal or potentially even high. Although I did my best to keep this simple and make the argument that the ScVO2 is a good monitor of our cardiac output, of course the other half of this equation is the oxygen consumption or the demand of the organs. Increasing your VO2, which is your oxygen consumption will increase your oxygen extraction and therefore decrease your central venous sats and mixed venous sats. You have three variables here. You have the cardiac output, which is your supply, your VO2 as the demand, and oxygen extraction. And unfortunately, you need two of these to calculate the third. So up here where I was making the case that a decreased central venous sat means that we have a lower cardiac output, I was making the assumption that we have somewhat of a normal VO2. If instead we're trying to say that a decreased venous sat is from a high metabolic demand of the patient, then we have to make some assumptions about the cardiac output. These variables, of course, are coming from Fick's equation, which is VO2, or your demand, is equal to the cardiac output times your oxygen extraction, which is the content of arterial oxygen minus the content of your venous oxygen. Unfortunately, there are quite a few things that can globally increase your oxygen consumption. All of these hypermetabolic states, like fever, inflammation, sepsis, burns, trauma, and even surgical stress, and also anything that increases your muscle activity, like shivering or seizures. And don't forget about malignant hyperthermia, which is a hypermetabolic state caused by unregulated metabolism in your muscles. Having clarified what our venous sats really mean, let's come back to this example of sepsis, which again is distributive shock with this added layer of a high metabolic rate, at least initially. This patient is going to be presenting with warm shock. This person will have low blood pressure as a result of a low systemic vascular resistance, but right now they're compensating and actually have a higher than normal cardiac output, thus warm shock. Let's say we do a central venous O2 sat on the person and it reads as 65%. So this person has a higher than normal cardiac output. So if their metabolism was normal, we would expect this venous sat to actually be high. So this suggests to us that they're actually in a hypermetabolic state. And they have a higher amount of oxygen extraction because they have a high oxygen consumption rate. So let's give this patient some alpha-1 agonism with our first-line vasopressor, norepinephrine, and there will be some beta activity there as well. This should increase their systemic vascular resistance and therefore increase their blood pressure. Our cardiac output is going to be relatively unchanged by this therapy. So if we do a central venous gas on this person, we may find that they have approximately the same venous sats. So we can ascertain that they're still in a hypermetabolic state. And our vasopressor caused a positive change to their blood pressure without adversely affecting their cardiac output. Now let's show two different directions this patient can go over the course of the night. First option, blood pressure drops. We've left everything else the same, so we don't really know if this is because of cardiac output or systemic vascular resistance. We're going to send a central venous O2 sat and here find that it's dropped to 50%. This could suggest two things to you. One, that you have lower cardiac output because we have a higher oxygen extraction, so perhaps we're sending less oxygen to them. Or we have intensified their hypermetabolic state. And in this case, it would be very reasonable to wonder if perhaps they have some myocardial dysfunction now as an end organ result of their sepsis, or perhaps they have hypovolemia and low preload, and they may be volume responsive. In either case, there's a high likelihood that decreased cardiac output is this patient's problem. A different direction they could go is, again, low blood pressure, and we haven't changed anything else, so we don't know about their cardiac output or their systemic vascular resistance, but we do a central venous gas and find that this is now 80%. Your options here are either that you've significantly increased their oxygen delivery, so we've increased their cardiac output, or decreased the metabolism. Well, technically, along with cardiac output increasing the oxygen delivery, you may have given this person blood if it was indicated, or increase their O2 sats, and that would also increase the oxygen delivery to the tissue, and perhaps that explains this. But in absence of anything that clearly would have increased their cardiac output, like further resuscitation to improve their preload status, or maybe a significant increase in heart rate, you may be starting to wonder if this patient has moved on to a phase of their sepsis where they are globally hypoperfusing and they're having microvascular dysfunction, as does happen in sepsis, and especially in light of their overall worse blood pressure, which suggests to you that they may be actually getting worse. And that would be supported by this high venous sat, meaning that the patient is doing a poor job of utilizing oxygen. I wanted to use sepsis as this example because you can take it in a bunch of different directions, but want to point out that the surviving sepsis guidelines actually do not instruct the use of central venous sat monitoring to guide resuscitation, probably because it really isn't black and white and does require quite a bit of interpretation with the clinical context. If cardiac output is truly all you care about, then there actually are much better cardiac output monitors out there, namely thermodilution and even echo. Overall, the central venous oxygen saturation is still a good monitor of your global relationship between blood or oxygen supply and demand throughout the entire body. I just want to blast through this last little bit, which is the calculation of VO2 using Fick's equation, just because you may at some point be asked what this equation is. So you may be asked to calculate either cardiac output or VO2. Here you're going to assume a cardiac output of 5 liters per minute. The content of your arterial blood is going to be your hemoglobin concentration times 1.34. So let's make this person have a hemoglobin of 120 times 1.34 times the saturation of that, which is going to be 100%. So times 1 is going to give us 160. This last term I'm just ignoring because the CaO2 times 0.0031 is so insignificant. Like this might be 80 times 0.0031 will give you less than 1. So that will barely budge this number. And then your content of the venous blood is going to be your hemoglobin times 1.34 times the venous sat, which we'll say is 75%. 1.34 times 0.75 will give us 120 mils of oxygen per liter. The difference between our arterial content and venous content then is 40 mils. So this guy's using 40 mils of oxygen per liter of blood that circulates through his body. 40 mils of O2 per liter. times 5 liters per minute gives us a VO2 of 200 milliliters per minute. In case it's not clear, this second term, 0.0031 times the oxygen tension, is just accounting for the oxygen that's dissolved in the blood that is not bound to your hemoglobin. And this is just such a small amount of oxygen that it really doesn't matter when you are looking at a person who is not anemic and who has reasonable oxygen saturations.